Today I'm going to present an uncommon case of sarcoma. Actually, it was a case of alveolar soft sarcoma. And you know that alveolar soft sarcoma is one of the rarest sarcomas. Soft tissue sarcoma make up about 1% of all cancers, and SPS makes up only 0.2 to 1% of all soft tissue sarcomas. There are about 80 cases diagnosed per year in the United States. And since that epidemiologic studies of US population between 1973 and 2014 identified only 267 patients with this diagnosis. And as the number of cases are very less, so we have very less papers, less research on this particular case of alveolar soft sarcoma. Anyway, I will try to present the case. In our case, actually he is a very young gentleman. Actually he was a doctor, he was a young surgeon. So while combing his hairs in the morning, he noticed a small swelling on left parietal bone. So incidentally, he found a palpable swelling in his right side of head, which was about 2 centimeters in size, hard in consistency. It was non-tender with free overlying skin. And it was gradually increasing in size for about a month. And after 1 month, he went to another doctor. And he advised him a X-ray skull, PA and lateral view. And in this X-ray, you can see that there is a lytic lesion in right parietal bone and another lytic lesion in the midline. So seeing this skull X-rays, he was advised to have a CT scan of brain. He went to the actual neurosurgeon, because neurosurgeons all are his colleagues. So he talked to the neurosurgeons. And on 14 February 2019, that CT scan was done. And in the CT scan, you can see that this is the brain window and this is the skull, and there is a destructive lesion in the right parietal bone, and also another lesion, sorry, this one in the midline and this one in the right parietal bone. But there was no lesion in the brain parenchyma. You can see the ventricles are so nicely, there is no shift of midline, and all other structures you can see very easy and clearly. And this is the bone window of the same patient, and here the lytic lesions of the bones are very well seen. Here, here, and here. And this one is the midline lesion, and this one is the right parietal bone. And the same patient in another scan, this is the midline lesion, and that other one was the right parietal bone lesion. So, as he is a surgeon and the radiologist was also following the scans, so he advised, okay, these are 3D images, and you can see that lytic lesions are better seen in these scans. So the radiologist was also watching his scans, sitting in the console. So we have done MRI of brain of the same day. So when we did the MRI of brain, you can see that there is a lytic lesion. Slightly, it is bulging outward and inward. But inward bulging was very slight, and it was not abutting or compressing the brain parenchyma. There is no pressure effect. And this is the same lesion, and there is no lesion in the brain parenchyma. Again, the same in the midline. This is the midline lesion, and this is the superior sagittal sinus. You can see that it is slightly compressing the superior sagittal sinus over here. And here also that it is just indenting but not invading. And you can see the ventricles are also nicely seen, the corpus callosum and brainstem, and everything were fine. Okay. I think you can give me the micro. Some of them I cannot listen. I can take it. So this is the axial window, and in axial window you can see the images. This is the lytic lesion marked with arrows. Hello. You can see the lesions very well. Sorry. So after the MRI, the doctor, he advised him to do an FNAC of the lesion. And this is the FNAC slides, and this is the high power slide, and this is the low power resolution microscopic images. And the FNAC findings were positive for malignant cells, suggestive of metastatic, poorly differentiated malignancy with unknown primary. So as there was no primary elsewhere, clinically nothing was there except that secondaries. So they advised that. First, later on they did the chest X-ray, and in chest X-ray there are multiple small soft tissue nodules. If you look at carefully, you can see it's a small lesion here, and a small lesion over here. Then whole body PET CT was done on 19th February, as there was no primary lesions we could find. And during PET CT, first we do the lung window images. It is our practice to see the lung first. And in the lung window, you can see there are nodules. Here is nodules, pleural based. There are small nodules here, here. This is the right lung, here, here. These are the pulmonary nodules. So if otherwise not proved, these are the secondaries. And in mediastinal window, you can see less lesions, but still you can see that there's a lesion over here, there's a lesion over here, there's the same lesion here, and there are a few smaller lesions elsewhere. Then the fusion images and the MIP images. And in the fusion images, you can see that there are some lytic hypermetabolic lesions in the posterior part of multiple ribs here, 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 here. And the skull lesion you already have seen in the skull X and MRI. It was there also, but it is not clearly visible. But this scan is only up to the knee joint. As the patient was long, it's quite tall, so we have done the top of head up to knee joint first. So here we could not find any primary lesion. Then the next part. Oh, yes. Now in this part, while I was also watching all the images sitting in my in the console. So then I saw a hypermetabolic elongated lesion in right anterolateral aspect of the right leg, and here also you can see the lesion. It has taken up the quite significant amount of contrast. FDG, and in the MIP images you can see the lesions. So seeing these images, I went to the boy. Actually, he was a boy. He was like my younger brother otherwise. And I examined him personally, and literally I could not find any lesion, because the lesion was around the socks marking. So when we put on the long socks, so it puts a mark on the skin. So the lesion merged with that markings of the socks. So it was not very much visible. But next day when he left the socks and came again, then if you look very carefully, there is a mild swelling over there, but no pain, nothing was there. Nobody will believe that it can be a so dangerous lesion. So next day, so I commented the report that hypermetabolic soft tissue mass within the muscle in anterolateral aspect of lower part of right leg, suggesting primary lesion, with secondaries in skull bones, multiple ribs, and in both the lungs. Biopsy from the mass of leg is recommended. So next morning, first we did the MRI of his leg, because if we do biopsy, then MRI will not give erroneous results. So in MRI, we have seen that there is a lesion. This is the coronal fat set image. This is sagittal fat set image. This is the tibia. And on lateral aspect, this is the lesion. And in T2 axial images, this is the lesion. And in axial fat set, this is the lesion. And in diffusion weighted images, we have seen that there is a restriction of diffusion within the lesion. And post-contrast images shows very high contrast enhancing lesion in the leg. So after that, I have done the ultrasound, and during ultrasound, this is the longitudinal scan, of the leg, and you see that there is a lesion over here. And when I put the Doppler on, and I have found that this is a very highly vascular lesion, that these are multiple blood vessels. And this is the axial scan, and you can see the same lesion over here, and also in Doppler images, there are multiple lesions. So after this, one of my colleagues who is doing interventional radiology, he did this ultrasound-guided coronal biopsy. And these are the biopsy samples that we have collected from the lesion. And we have sent it to the histopathology department. And these are the histopathology slides. This is the scanning view of the histopathology slide, and this is the high-powered magnified view of the lesion. And as per the histopathologist, it was typical of soft part sarcoma. They have given the report like this, alveolar soft part sarcoma, and at that time immunohistochemistry was going on for further evaluation. So after 2 to 3 days, they have given the histopathology immunohistochemistry report, and it was Desmin negative and MIOD1 were also negative. So as Desmin and here both were negative, so these were done to exclude rhabdomyosarcoma, and they advised for immunohistochemistry for TFE3. After this, the patient left the country and he went to Singapore to further evaluation of the process. So first he went to Singapore National University Hospital, and they have given the same report, immunochemistry, tumor cell shows diffuse nuclear positivity for TFE3. They have found that TFE3 were there, and they have given the report that alveolar soft part sarcoma, TFE3 plus. And again, the slides and blocks were reviewed in National Cancer Hospital, Singapore, and they have given the same report, alveolar soft part sarcoma, TFE3 plus. So final diagnosis, yes, alveolar soft part sarcoma, TFE3 plus with metastasis. So treatment, with the consultation of group of oncologists, tablet pazopanib 800 milligram per oral, the daily started on 8 March 2019 due to metastatic alveolar soft part sarcoma. One of our colleagues is still here, Dr. Ilahi. He was also part of the team in treating this patient. So this was the follow-up advice that repeat the following tests 15 days after the starting of therapy, that is full blood count, liver function test, renal function test, and review of the patient after 3 months with whole body CT scan and MRI of right leg and brain. So after 3 months, we have done in May 2019. And in that scan, we have seen that the same lytic lesion in the right parietal bone. And in the lungs, the lesions were there. There was no significant change still then. And this is the mediastinal window images. This is the mediastinal, the lung nodules. Then we have done the MRI. And in MRI, if you look very carefully, you see that the lesion has slightly more bulging into the cranial cavity. If you can remember my first slide, that is slightly more indenting the superior sagittal sinus and compressing it. And the images also, here also you can see it is slightly more bulging than the previous one, here also. And in post-contrast, the same thing, that it enhanced vividly. This is the coronal images post-contrast, and this is the sagittal post-contrast images. And we have done the MRI of leg also at the same time, and the primary lesion was of same size and without any significant change. After the first follow-up, it was seen that his lesions were slightly progressing. Tablet pazopanib was discontinued and sunitinib was started. but he could not tolerate the side effects of sunitinib, and immunotherapy, that is PD-L1 inhibitor, was started. So regular follow-up was being done every 3 months, and we have been watching. I have not got all the series, but I'll show you few. Gradually his condition was deteriorating, and in between he was also attacked with COVID-19, but it was not that severe. So follow-up CT scan after, I'm showing that scan that was done 2 years later. In between I have all the series in my house, but I'm showing the 2 years. And in that scan, you can see the secondaries has become larger than the previous one. This is the sagittal image. In coronal image, you can see that it has grown further, going outward and inward at the same time. And the lesion in the midline, it has also become bigger. The bony part also become bigger. And in lung window, there was a slight increase in size of the nodules. So it was not improving. In between, he had respiratory tract infection on few occasions, and in one occasion he was so ill that he had to be brought into ICU. And later on he recovered and again started working. This is the follow-up about 30 months on 5th August 2021. And in this lesion, you can see the lesion has grown further, the lesion of the parietal bone. And this is the lesion of the parietal bone. And there is another lesion in the occipital lobe of left cerebral hemisphere. That is secondary in the brain also. Previously, we did not find any secondary in the brain. But after 30 months, we have found that there was secondary, but only one secondary was there in the brain. And this is the post-contrast images. You will see there are enhancement. This is the sagittal image, and this is coronal. And this is the axial image, and you can see the secondary in the left occipital lobe. Unfortunately, we could not save the patient. He left this world only 30 months after the diagnosis and started his eternal journey on 19th August. Actually, when I start talking about him, I became emotional because he was so close to me. So alveolar upper sarcoma is a very rare tumor worldwide. The pattern of representation in this case is also very peculiar and unusual. Comprehensive teamwork of radiologists, pathologists, oncosurgeon, radiation, and medical oncologists is of utmost importance in the diagnosis and management of alveolar sarcoma. So we need to communicate with each other and work together to fight against these deadly diseases. And about this picture, this is one of my very favorite picture, and also at the same time it is symbolic. So in this picture you can see this is the lighthouse, and the light is on there, and outside the sun is going down and everything is going to be dark. So lighthouse is the object which guides the captain of the ships to go to the destination correctly and safely. So as a radiologist, we want to work as a lighthouse because I am not the captain of the ship. I can only show you the pathway, or I can guide you to some extent. But you are the captain of the ship, patients are with you, and you have to, so that you can treat them correctly and properly.